what is skull-base surgery?
Skull base is that interface between the brain and the structures below the brain. Just below the brain, you have the sinuses and you have the ear. And that extends all the way back. Unfortunately, I do not have pictures, but basically, and then the structures very close there. Sometimes it's more accessible by combining a neurosurgical and an ENT approach, provided the ENT surgeons had specialized training in dealing with approaching those areas. So for example, there are patients that have brain tumors and we go through the ear to get at it, which means the surgeon doesn't have to cut through a lot of brain tissue, doesn't have to pull it around, and the patient actually has a faster recovery and minimizes the risk of things like strokes and all that. Because the brain can be very sensitive, and there's some areas of the brain that can be sacrificed. Some places have to be sacrificed, but everything has a consequence. But if you have, for example, a patient with a brain tumor which has already caused a patient to be deaf, the effects of further deafness is negligible. And all you're looking to do is make sure that you are able to do the surgery causing less problems for the patient. And that's where the skull base started to arise. Something that was generated in the States by the pioneer of skull base, William House, in the States pioneered that type of surgery, and it's blossomed since then. And even nowadays, there's a more tendency to use an endoscopic approach anteriorly, that's through the front, going back to the pituitary gland, which is in the front, and also structures around the brainstem to deal with tumors around that site. And
you said something that some senses can be sacrificed. You used the example of a deaf person, for instance. What if the person didn't have any disability prior to that surgery? What senses would you choose? How would you decide which sense to get?
Certainly, the skull-base judgment would generally try to avoid causing further morbidity and further problems for the patient. And more often, if you have tumors and things around that structures, those structures are already involved. For example, there's certain kind of growths that will affect the voice already. The patient's already hoarse, and all you're trying to do is remove the tumor without causing further swallowing problems. The patient may well have that, and then you can have restorative procedures to try and improve the voice or improve the swallow. So there are structures, most of the time when you have structures around these areas, they're already damaged, and all you're doing is trying to remove the problem or reduce the problem without giving the patient additional things to worry about. Sometimes you have to make a judgment, and you know the other side is working, and functionally the patient may not necessarily have a problem, even though you know that you've reduced the patient's ability to function. So there may be some complications that you cannot avoid, but it's something that you can manage, and the patient becomes functionally able to cope with that change.